All right, we're going to talk about some mostly clinical concerns, clinical issues with swallowing, and then just a couple other things that I wanted to make sure that you learned about that weren't covered in some of the other videos. Also, this is a big... I think this is ramen made with beer, and it's pretty terrible. Anyway, all right, so... One of the things I wanted to talk about are the problems that can come from disordered swallowing. I mean, first of all, eating and drinking are important for your usual things. It's the main way that you're going to hydrate yourself and obtain nutrients. But beyond that, it's also the way that we kind of get together with our friends, right? So happy hour is... you go out after work and you have drinks or food or something like that, and kind of centers around eating or drinking. And it's not like you're going to go to a library and just kind of sit around with your work friends. And if a friend comes in from out of town, it all kind of centers around eating. So there's things beyond just feeding yourself and hydrating yourself that are important to go along with a typical swallow, or helping someone be able to swallow normally. If they're aspirating their food or drink all the time, they might not want to go out to these kind of outings, and they're going to end up isolating themselves from their peers, right? All right. So then other things that can come from disordered swallowing. I mean, we've kind of run the gamut from not so terrible to really bad. You can end up with drooling, which is a little embarrassing but not terrible. Painful swallowing, heartburn, acid reflux, and you've heard in some of the other lectures that acid reflux is particularly bad for speech. I mean, it can be, right? It's bad for other things. It can lead to esophageal cancer, laryngeal cancer, but then also it can start to affect the vocal folds as well. So you can go from just having swallowing problems to ending up with speech problems as well, and potentially cancer as well. You can also end up choking on food particles or aspirating your drinks. Aspirating just means breathing it in. And then one thing that can happen when that is a problem, I mean, we do it all the time. I do it with my coffee a ton. At least once a day, I'm going to I think it's because I drink like a weirdo. But I kind of bring drink into my mouth that way because I'm very, very nervous about backwash. My own, other people's. It's a problem. Anyway, so at least once a day, I'll inhale drink, but it doesn't go too far in. I'm able to cough up whatever I've inhaled, and there's that ghost again. There we go. And take care of it. But what can happen with people who aren't able to to catch that, if it's a lot more larger amounts of food or drink that they're aspirating, you can end up with aspiration-induced pneumonia. And here, this is what that looks like on an x-ray. So this person has aspiration-induced pneumonia, which essentially means that they've aspirated something, usually a liquid, could be food. Food might be harder to cough up out of the lung, as you can imagine. And that becomes an infection. That infection turns into pneumonia. Now you've got this respiratory problem, and it can, spread from there. It can get worse from there. And so this person has, they call it consolidation, but you can see that there's a difference in tissue here. And what that means is that there's not enough open space for air to flow. There's swelling, there's increased mucus, just everything that's making the lung more dense in this area, which doesn't allow for as much air to enter the lung in that area. So you have this pneumonia, and in addition to the infection you're fighting, you're only getting about maybe 50% of the air capacity that you should on that side of the lungs. So this slide, you pretty much got all of this information, but I wanted to give it to you in the actual trajectory that you would move through if you're eating something, right? So I'm gonna post these slides for you so you can take a look at it. I guess I shouldn't tap the side of my computer because that makes the camera go all crazy. I'm going to post these for you. You can look at the trajectory, but essentially you're going to use the cheek muscles and the mandibular muscles to chew, muscles of the tongue to keep the bolus on the tongue, and then to start pushing it back. And there's reflexes in the mouth. Remember, the facial pillars is where the swallowing reflex begins. Then in the pharynx, the velum is going to close, the larynx is going to move up, and the epiglottis folds down to cover the airway, allowing the bolus to move into the esophagus. And then in the esophagus, the upper esophageal sphincter will relax. And the esophagus, remember, is one of the few structures, one of three. I only have one other listed. That's my bad. But it's three. It's one of three that pass through the diaphragm. The other two are both blood. One leaving the heart, one returning to the heart, so it's okay. But this is one of the three structures that are going to pass through the diaphragm. That could be important for you to know on, say, an exam. All right. So teeth. These are something that you haven't covered yet. Well, that's not entirely true. We covered them a little bit in resonance and articulation, but I want to go over them again. There's some other points that need to be made here. So, all right, so you've got your incisors, which are up here. These two guys here, these flat blade-like teeth. It means to cut, which makes sense. They kind of are shaped like blades. They're kind of shaped like sharp, flat shovels, I guess, but whatever. They cut food like small knife blades. They're really good for taking the first bite of things. Then you've got these canine teeth. Those are obviously named after dogs, which have large canines, and they're really good for ripping food. So you can kind of cut food and then rip food. So you're going to cut with the front teeth, you're going to rip with the canines. There's one of those in each quadrant. So I'm talking about numbers in terms of quadrants. So if you think about your mouth as half, if you go across this way, so you got a bottom half and a top half, and then you cut that in half again. So the upper left portion of your teeth, that's just one quadrant, right? If you look at this, I don't know, it's not really a person, this model right here, if you cut right there, and then everything over here, this is all one quadrant. So there's two incisors, there's one canine, then you've got two premolars right here. These premolars are partway between canines and molars. Makes sense, right? They're good, they're good for ripping and grinding. So you can see that they have these kind of pointy structures, a lot like the canine, but then they've got this interior portion that's good for grinding food as well. And then molars, you've got at least two in each quadrant. It means millstone. Those are really good for grinding and crushing things as well. And consider why they might be good for grinding things. I mean, they're good for grinding things because of the shape. But then also, in addition to the muscles that are pulling up on the mandible, you've got a tight band of muscle right around here, right, that is going to allow you to crush, pull up, and then also this is where you get the side-to-side motion as well. I mean, you have the side-to-side motion in your entire jaw because it's all moving, but the muscular forces are really at play right back here. So you're going to get most of your power in the grinding motion is going to be right here. Most of your power in the actual bite, because the leverage is going to come in the front, and then the shape of the teeth allows you to kind of bite through things. But the grinding power is going to come towards the back. And then vampire fangs, typically made of plastic, usually worn around Halloween, and that's a whole different type of teeth, right? So if I ask you on the exam numbers of teeth, it's going to go 2, 1, 2, 2 plus. So really all you have to remember is it's a series of 2s. The last one is 2 plus, and then there's 1 canine in there. So 2, 1, 2, 2 plus. Right? Yes. Okay. So we know that you breathe while you chew, right? So think about where the velum would be if you're breathing while you're chewing. Your mouth is probably closed while you're chewing. Let's say it is. I mean, sometimes it's not, but let's say it is. Let's say you're at a fancy dinner party, so you're closing your mouth while you're chewing. So you can, chew, and you can breathe at the same time. So your velum is going to be down. Air is passing, through the nasal passages into the trachea. So the velum's down. But the velum is going to close when you start the swallow. I know that's kind of out of sync with what I'm talking about here. And that's because I usually use that as a little quiz in my in-person classes, just to get them to think about the position of the velum before we talk about it again. So it's not bad also to you guys think about the position of the velum before we talk about it again. All right, so salivary glands, we've gone over these already, but as a little review, you've got your parotid salivary gland back here. It's the largest one, and it's the most posterior. So parotid, posterior, P, hooray. And then the other two, these are going to be pretty easy to understand, right? So you've got submandibular, it's down here at the bottom of the mandible, and then sublingual is going to be under the tongue right here. And actually, I believe these two share a salivary duct. So this tube is going to come up from here and pass by the sublingual gland, and then those will kind of share the same duct that comes out under your tongue. All right, so what's in saliva? There's a lot of really cool stuff in saliva. Saliva is actually like super cool. It's like gross, but it's cool. So there's an amylase in there, which is going to break down starches, and then there's lipase inside, which also breaks down fats. There's a ton of antimicrobial agents too, which is good because then we can eat all sorts of disgusting things and not get sick. You can pick up the 5-second rule. Basically, is what I'm talking about here. So drop some stuff on the floor, pick it up, eat it, you're fine. It's because you got these great antimicrobial agents in your saliva. Also, chewing gum. This isn't really necessarily an SLP thing. This is kind of a dentist thing, which I'm not a dentist. But chewing gum, you've probably heard this, that it's clinically proven to contribute to the health of your teeth, right? If you chew for 20 minutes after a meal. And if you've heard that and wondered why would chewing gum have anything to do with contributing to the health of my teeth, it's actually because it increases saliva production. So what's going to happen after a meal is it's going to help clean off your teeth. All of this extra saliva, you're going to kind of flood the mouth with the amylase and the lipase to break down any starches and fats that are on the teeth. And then also, I don't have this on there. Dang it. No, I don't. There's also a lot of minerals that are in saliva as well. And those minerals are going to contribute to the health of the enamel of the tooth. So kind of bathing the tooth in this mineral-heavy solution will strengthen the enamel. So after you eat, you wash off your teeth essentially with just saliva, with this amylase and lipase, and then you're kind of strengthening the enamel. So if you're one of those people who brushes after you eat, first of all, good on you. I don't brush after every meal. But you should still chew the gum, because the brushing is taking care of what the amylase and the lipase are doing, certainly. But the toothpaste isn't bathing the teeth in the mineral solution, essentially, to strengthen the enamel. So you should still consider chewing gum. So let's run through the swallowing procedure, the steps of a good swallow. So first of all, as you know, the velum is going to elevate. Respiration is going to cease temporarily as you swallow. So obviously this is happening physically, like you are not breathing when you swallow, but it's also a reflexive action, right? It's that apnea portion. So the vocal folds and false vocal folds are going to adduct. I don't know why I pulled away. That's not what I should have done. So they're going to come together. The epiglottis is going to close. The larynx is going to elevate. And the cricopharyngeus muscle is going to relax. That's the motion that I'm looking for there. The cricopharyngeus muscle is going to relax. Usually the cricopharyngeus is in tonic contraction. And as you know, that forms the upper esophageal sphincter. So it's going to relax and it's going to allow the food to move down. Also at this point, the lower esophageal sphincter is not relaxed, right? So the upper opens, the bottom is contracted, and then this closes and the bottom opens. This is important when we talk about vomiting. So vomiting is a completely reflexive movement, and it's almost exactly the reverse of swallowing, except the lower and upper sphincters are going to open simultaneously. So it's kind of like, open the floodgates, release the kraken. You shouldn't have swallowed a kraken, so now you're going to throw up. The abs are also going to contract. So they're kind of what's really pushing on the stomach and shooting everything out. So upper and lower esophageal sphincters open, abs contract, and then again, the larynx is going to move up, the velum is going to close. Thank God. You don't want vomit getting in your nasal passages. And then also the tongue is going to protrude reflexively. I mean, like we kind of joke about it, right? When you kind of like mime vomiting, you go like that. But it does happen that your tongue protrudes. Also, the vocal folds are, adducted. The epiglottis is closed. One of the funny things that happens sometimes is if you think about people make a noise, right, when they vomit, and this is probably will gross you out a little bit, but it's also to kind of tie some things back into respiration. So the abs are involved in vomiting, but the abs are also involved in pushing air out during forced expiration, right? So what happens when air gets pushed out and the vocal folds are adducted, a sound is produced, right? So then there's phonation. So what happens sometimes when you're vomiting is you accidentally get this phonation because you're pushing on the abs contract to push on the stomach, but it also pushes on all of the abdominal contents, which then forces the diaphragm up. It pushes air out of the lungs. The vocal folds are adducted, and so then you get a noise that's made. And this noise can escape, around the epiglottis. And so what happens is you have this involuntary phonation, this involuntary sound that's produced while you're vomiting. Hooray! Now you know a gross fact. One thing that happens typically with aging is that the place where the swallowing reflex, the place where the swallowing reflex begins kind of starts moving posteriorly. It could be due to desensitization of touch. It's possible. Another thing is the research in this area for a cause is poor. There's not a lot going on. So it could be desensitization, it could be something else. But it does start to move posteriorly for older people. I say inferiorly too because it kind of moves a little bit. It moves back in the mouth and a little bit down on the tongue because the tongue slopes down towards the back. So again, we don't know why, but this can lead to liquid and small chewed up bits of food kind of pooling in the valleculae. This is not good because you can aspirate it, right? So I've got this video that we can take a look at really quickly, and this is going to show you what happens with this premature spillage. Okay, so this is all... Oh, I don't have my laser pointer thing because I'm not in. Anyway, all right. So I do have a pointing deal. So this is accidental, right? This is kind of flowing back from the tongue onto the epiglottis, which is right here. The valleculae are on these, kind of down in here, and so you can see it pooling over these. This should be down during a swallow, right? And you can see here the vocal folds. These are the vocal folds down here. These are open because this person is breathing right now. They're just in the chewing phase. Or actually, this is it's a general solid, so they probably are chewing this a little bit. This is an endoscopic look at the swallow. So you can do this with like different solidities of goop, basically, is what it is. And so this one, it says general solid here, so this is probably something that starts out kind of solid, like a yogurt or like a cottage cheese, and then the person's going to need to chew it a little bit. And so what we're seeing here is, while this is being broken down into more of a liquid form, this spillage is happening. Again, I want to point out that this person is breathing. And the epiglottis are closed, so you can tell that there's too close for comfort. Oh no. But they swallow. So every time the camera gets kind of occluded like that, that's a swallow. Here again is another swallow. But you can tell. All right, so that's issues with swallowing, kind of premature, there we go, laser pointer thing, premature pooling of food prior to the swallow. And this could be due to this swallowing reflex moving back. One of the things that you can do to help enhance the swallowing reflex is you can try to have people retrain. And what you can do is you can make the swallowing reflex happening by applying cold up here, like further up. So on the facial pillars, on the anterior facial pillars, you can apply something cold or something sour and a little bit of pressure, and that can help start the swallowing reflex too. So one thing that people do a lot of times is they'll take lemon juice and they'll put it on a cotton swab, and then they'll throw that in the freezer. And so then what you get is you get sour, cold, and pressure. So you're going to push it on the facial pillar, and this is going to trigger the swallowing reflex. What you can do is you can try to build up a stimulus response kind of behaviorism learning, like a Pavlov's dog kind of thing, and retrain the swallow that way. All right, so here's another one. Where did my title go? This is weird. So this is called a pulsion diverticulum right here. And essentially what happens is it's going to start with disordered swallowing. So some of that like painful swallowing, or sometimes if the cricopharyngeus muscle is too relaxed, you can end up with this as well. So what happens is these different types of disordered swallows are going to create different pressures in here than a person would have with a typical swallow. The weakest part of this inferior constrictor, which is here, and the cricopharyngeus, which is here, is something called Killian's triangle. Not to be confused with Killian's Irish Red, and it's almost St. Patrick's Day, so go ahead and have a pint. Anyway, this little area right here is called Killian's triangle, and you can see that the fibers, the muscle fibers in this area right here, I mean, this is the beginning of the pulsion diverticulum. So if you imagine this not being there, let's see, it would kind of look like this area between these muscles. So you can see that there's like a different zone here where the two muscles kind of come together. First, I should point out the cricopharyngeus is part of the inferior constrictor, which is kind of weird because the inferior constrictor mostly, this upper part, the part that we talk about as being one of our laryngeal muscles, one of our pharynx muscles, connects to the thyroid cartilage here, and then the fibers kind of course upwards towards the raphe. see these kind of curving upwards like this. Now this right here, the cricopharyngeus, connects on the cricoid, which is in the name, so that's nice. And then it doesn't course upwards, it just courses, kind of laterally. Actually, it would be posteriorly, but on this picture it's laterally. So they're going to course like directly, like straight across in a horizontal fashion towards the back. The inferior pharyngeal muscle proper is going to course kind of up. But they are part of the same muscle. Odd. They'll innervate slightly differently too. Same nerve, but the way that they innervate is different. So the cricopharyngeus is under tonic contraction, which means it's usually just in a state of contraction. But the inferior pharyngeal constrictor, not so. It can contract with the motions of with the larynx as needed. So they are part of the same muscle, even though they do very different things and they seem very different. So you have this portion where the fibers start moving in different areas. Right out here at the very end, there's not a lot of contraction that can be put on that zone. That's Killian's triangle. And so when you have these extra pressures, the esophageal tissue in that part, in Killian's triangle, can slip out between those two parts of the muscle fibers. And that becomes the pulsion diverticulum. It's also called a Zenker diverticulum, if you want to look it up. So what ends up happening, this is the pulsion diverticulum here. It can grow larger and then kind of flop down like this. It's painful, as are most diverticula. It can cause infection. That's usually why it's painful, is the swelling in this area. This can cause, you start with disordered swallowing, but this can cause further disorders of swallowing. What can be done to the pulsion diverticulum is that you can have a surgery to remove this extra part. You can have, it's better over here. You can have a surgery to remove this extra part right here. And then what they do is they just patch together the esophageal wall. Then they'll also patch together the muscle tissue here. So they'll more solidly put together the cricopharyngeus and the inferior pharyngeal constrictor so that they can't slide apart anymore. There are some new methods where you can kind of come down and, using an endoscope that's been fitted with a little surgical manipulator on the end, you can actually just kind of come in, laser this, and then either cauterize or staple or suture the skin and the muscle back together right here, all in one endoscopic procedure, instead of having to go in and actually, do these things by hand. And that is great because this usually affects aging adults who heal a little bit slower. They can have secondary problems with anesthesia and stuff like this. So you can do a much faster procedure, so there's not as much anesthesia. There's a smaller wound that needs to be healed, so it's just better in general. This is the kind of thing that SLPs can't work on, but you can definitely see this, and you can notify the MD that this is going on and they're going to need some sort of surgical procedure. You can also look for the precursors to the pulsion diverticulum as well, like some of these other swallowing disorders. So if they have a swallowing disorder that seems to be putting extra pressure on the muscles of the above the upper esophageal sphincter, above the cricopharyngeus muscle, they might be at risk for a pulsion diverticulum. All right. And then I think this is my last slide. Yes. This is just a couple issues going along with sensation. So I don't know if you are as big of a fan of ice cream as I am, but I love me some Ben & Jerry's. And one hallmark of Ben & Jerry's are these like really large, interesting pieces of stuff that they have in there, right? Sometimes the chocolate pieces seem like they're molded in a very particular way to have like an interesting texture on them. And this is by design because Ben has a problem smelling and tasting. he is really big into textures. So he's really big into eating their ice cream because of the different interesting textures that they put in. There's a lot going on for somebody that can't smell or taste. There's the soft ice cream, there's chewy things, there's really crunchy things. And so that is something that he and other people with this problem really enjoy. If you think about where the nerves are that go to, like the hypoglossal nerve and other nerves that are governing our tongue innervation and taste and sensation like that in the mouth, they're pretty close to the outside of our bodies, right? So they're really susceptible to illness, surgery, and trauma. So if you have to have reconstructive surgery from a car accident or something, it's possible that a nerve might get nicked. It's possible that really bad sinus infections may start to affect some of the nerves. And so it is somewhat common to have neural problems, not neural problems, but neural as in nerve-based problems dealing with the mouth. These nerve-based problems, though, have a really strange set of symptoms. So some people, this is unilateral damage, I should say, so this is damage to just one side, right? So say the left side. And these are all done mostly with this hemi-anesthetized tongue. And all that means is that you just kind of inject an anesthetic, a local anesthetic, into the side of the tongue and let one half of the tongue fall asleep. And then see what sensation occurs on that side of the tongue and the mouth as a whole, etc. So this is really strange. Some people they show no effect. So this side of the tongue is deadened, and yet they're fine. It's like there's no deadening over there at all. And some people will report this coming from, the dentist, oral surgery as well. They'll get deadened up here in the teeth so that the skin and the gum can't feel anything when they're being worked on, and yet taste isn't impaired, tongue movement isn't impaired, and they're totally fine in the tongue, which is strange because others of us, like me, I have a loss of feeling on one side of my tongue. Taste generally seems to be impaired. For me, it's both. For other people in the study, it's one or the other. And then some have an impaired taste just to some things, not necessarily to everything. And this is true for me as well. It seems like when I go to the dentist and I have one side of my mouth deadened, bitter things are still able to come through on that side of my tongue. So the horrible thing that they have you bite on that begins the local anesthetic procedure, that taste does not go away. Usually when they have you bite on it, it's kind of mixed with a little bit of a sugary solution, so it doesn't taste as absolutely terrible. But as the deadening begins, this just bitterness kind of overwhelms the tongue. I also like to get milkshakes after I go to the dentist, even if it's just a cleaning, because I'm a princess. And when I've actually had some sort of surgery go on, I can't taste a lot of the sweetness that I'm looking for, which is a total bummer. I should probably wait a couple hours before I get these. You really learn about yourself when you give a lecture. This is absolutely nuts. So some have something called burning mouth syndrome. And it feels like their tongue is on fire, right? Or like they've just eaten the spiciest pepper that you can imagine. So that's kind of interesting. And you'll actually see cases of burning mouth syndrome, not just in the study, like people that have had damage to their to the nerves governing the tongue and innervating the tongue and bringing sensation to the brain will have burning mouth syndrome. And it's like a chronic symptom, like your tongue is always on fire. But because it's not actually sensing anything, putting something cool in the mouth or any of those things that try to combat spiciness don't work, because it's actually just a nerve sensation, an incorrect nerve sensation that's producing the sensation. It's a bad sentence, but you know what I mean. So here's another thing. We've talked about the research with a lot of taste stuff is poor. This is no exception. There's not a lot of research that goes into the proprioception, the different touch sensations in the mouth, the different tastes, the smells, and all those different things. In normal people, there's not a lot of research. But in clinical populations, there's even less research. So if this is something that's interesting to you, and you are one of the people that are taking this class that begin to think that maybe a PhD in research is for you, this area, I mean, nobody's doing work in it. There's a couple people doing work in it, but you would definitely find a place to do your own research in this area. And it's a really interesting kind of fun area too. I mean, it's not fun if you have burning mouth syndrome, but it's an interesting problem. All right, that is the end of the lectures for this module. What's coming up next for you is definitely study for this exam. I'm going to put up a review as always. Take this exam. Then I highly suggest taking the optional final. Here's the deal. If you take the optional final and you totally bomb it, that's the one that gets dropped. If you accidentally get 100%, cool. If you know that you need the optional final, I'm going to post a review for it too, so you can look it over. But if you're comfortable with your grade, take it. Just, set aside 30 minutes. It's like a minute a question. Take it, see what you get. You might surprise yourself and get a better grade than you thought you were going to get. And you're already comfortable with it, so why not? Okay, I will see most of you in some of the classes that are coming up in the next 7 weeks. If I don't see you in there, I hope that you've enjoyed these lectures and learning about some of these things. Try to keep a lot of the clinical concerns in mind. You're going to need those when you get into graduate school. You're going to actually be working in the clinic. You're going to see all these things. I mean, it's important to know the basic functions of anatomy and physiology in general for your future career. But also, people are not coming in because they're progressing normally. They're coming in because they've got a clinical problem. So you need to know the anatomy and the physiology and the clinical concerns. The more of this that you can keep in your brain, the easier graduate school is going to be for you, and the quicker you can, start helping people and making some of that sweet cash. So, all right, I'll see you guys later.